Hi, everyone, and thank you for joining us this morning. Welcome to the first installment of our York Circle at Home lecture series for the 22-23 academic year. This year's theme is the pandemic, COVID's impact on Canada's healthcare system. And today's topic is the aftermath. Where do we stand living with COVID for 2 years? My name is Julie Lafford, and I'm the Assistant Vice President, Alumni Engagement at York University. Although we aren't all in the same location today, we recognize the many Indigenous nations which have long-standing relationships with the territories upon which York University campuses are located, and they precede the establishment of the university. York acknowledges its presence on the traditional territory of many Indigenous nations. The area known as Takaranto has been caretaken by the Anishinaabe Nation, the Haudenosaunee Confederacy, and the Huron-Wendat. It is now home to many First Nations, Inuit, and Métis communities. We acknowledge the current treaty holders, the Mississaugas of the Credit First Nation. This territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably care and share the Great Lakes region. I'm grateful for the opportunity to live, work, and play on Treaty 13 land. But before I turn things over to our new York Circle academic chair, I want to mention a couple of updates from the university. York recently announced that Kathleen Taylor will serve as York's 14th chancellor beginning in January 23. The first woman to serve as chair of the board of a major bank in Canada, Taylor's appointment also marks the first time a woman will serve in the role. Taylor's an esteemed York alumna, holding a Juris Doctor from the Osgoode Hall Law School and a Master's of Business Administration from the Schulich School of Business. In other news, York advanced to the top 5 spot in a recently released Maclean's National Comprehensive University ranking. Universities in the comprehensive category have a significant amount of research activity and a wide range of undergraduate, graduate, and professional programs. Over the last 10 years, York has advanced an impressive 19 spots on the national reputation ranking, this year moving up to number 17 in Canada. With our highly ranked programs, award-winning faculty, unique hands-on learning opportunities, and strengthened support for our students, it's no surprise that York continues to be celebrated locally and globally. And now on to today's event. York Circle evolved into a virtual event in response to the circumstances of the pandemic, and we're continuing in that format for now. Although we're prepared and excited to host this series in person in the future, we learned that this format has been very well received by both you in the audience and our faculty members. And as always, we welcome the feedback from you, whether it's on the format or the content. And we've entered our email address in the chat, and I'll also mention some ways to connect with us at the end of today's session. If at any time you need help with this experience or you have questions about the content, feel free to click on the Q&A button at the bottom of your screen, and our team is in the background ready to help. You can use that same Q&A button to submit questions at any time throughout the presentation, and we'll respond to many as possible during the Q&A session. And now, without further ado, I am delighted to introduce our brand new chair and host for this series, Dr. Jennifer Steeves. She is the Associate Vice President, Research and Academic Chair of York Circle. Welcome, Jennifer. Jennifer is a professor in the Department of Psychology in the Faculty of Health and a member of the Center for Vision Research. Professor Steeves holds a Tier 1 York Research Chair in Non-Invasive Visual Brain Stimulation and is a core member of the Vision Science to Applications program, also known as VISTA. Welcome, Dr. Steeves. It's a pleasure to have you leading this series and to be working with you and to hear your insights on today's topic. I'll now turn things over to you to introduce the panelists.
Thank you so much, Julie. Good morning and welcome, everyone. Thank you for joining us on this beautiful fall morning for an exciting new York Circle series. As Julie mentioned, my name is Jennifer Steeves, and I am your academic chair of the York Circle Lecture Series this year. I am truly honored to be a part of this incredible series, and I look forward to showcasing the incredible research at York to our alumni community. Over the 2022-23 academic year, we will bring together multidisciplinary panelists to dissect and discuss 4 topics over 4 sessions under the broader umbrella theme of the pandemic's impact on healthcare in Canada. I'm excited to explore this theme together with you and my peers over the next several months. The topic for today's session is the aftermath. Where do we stand living with COVID for 2 years? Our first presentation is led by Dr. Pat Armstrong, who will examine COVID's impact on long-term care. Next, Dr. Farah Ahmad will ask e-health and equity, where do we stand? And finally, Dr. Skye Fitzpatrick will explore a scalable method of targeting PTSD in the pandemic. I am so pleased that Pat, Farah, and Skye could join us today. I know we will all learn very much from their presentations. Now I would like to introduce our first speaker, Dr. Pat Armstrong. Dr. Armstrong is Distinguished Research Professor Emeritus at York University, and she is a Fellow of the Royal Society of Canada. She has published books on healthcare, such as Wash, Wear, and Care, Clothes and Laundry in Long-Term Care, Critical to Care, The Invisible Women in Health Services, and Wasting Away, and Undermining of Canadian Healthcare. In addition to her books, she has also published numerous book chapters and journal articles and many, many reports. In partnership with unions, policymakers, and community organizations, Dr. Armstrong has led multiple team research projects, including a 10-year project entitled Reimagining Long-Term Residential Care, an international study of promising practices. And she is presently leading a team project titled COVID-19, Families and Long-Term Residential Care. Welcome, Dr. Armstrong. Over to you.
Thank you, and thank you all for being here on a Saturday morning. Healthcare is critical to us all, I'm sure. And I should explain, I am doing this from a hotel room in Montreal, and I apologize if my husband walks by in the nude. I think he's prepared to not appear. For well over a decade, our international interdisciplinary research team has been studying nursing homes in 6 countries: Canada, Germany, Norway, Sweden, the UK, and the US. We've been searching, as we just heard, for promising practices that would make residential care as good as it can be for residents, staff, families, and volunteers. We've done so by using multiple methods, including taking international interdisciplinary teams of 12 into nursing homes in all 6 countries to observe and interview over the course of a week. More commonly called nursing homes, we are studying places that provide 24-hour nursing care, that receive significant public funding, and are highly regulated. They're often confused with retirement homes or other seniors' congregate care facilities that are not very regulated and receive little direct public funding, although they house many more people than the nursing homes I'm talking about today. Healthcare, as we hear so often, is a provincial territorial responsibility. But the Canada Health Act makes federal funding conditional on doctor and hospital care being accessible, universal, comprehensive, portable, and administered by a nonprofit public agency, with medically necessary care provided without fees, which is important, very important. However, extended care is excluded from the legislation and varies considerably across Canada. So in looking at the short and long-term impact, as I was asked to do for today, I'm going to focus mainly on Ontario. Well, there's good news and there's bad news. I don't have to tell you that the worst news was the widely publicized tragedies of death rates in nursing homes, rates that were among the highest in the world. This news was combined with the horrors in the homes made real when the military publicly released their report on the homes they rescued. However, many more people became aware of the kinds of issues our research and that of many others had been seeking to expose for years. And the reporting drew outcries from communities across the province and across the country, I have to say. Some demanded fundamental change in nursing homes, while others wanted them blown up and replaced by home care. While there's no question that we need more and better home care, there's also no question that we need more and better nursing homes for the many who require 24-hour skilled care for their complex care needs. I'd be happy to expand in question period on my reasons for making this claim. So in the limited time available, and to make sure we hear your voices, I want to focus on 3 related areas where research and media stories highlighted the need for fundamental change, briefly identifying the issues and the government response to demands for change. My first issue is staffing, long identified as critical and an issue that became even more obvious with the pandemic, as I'm sure you know. Indeed, staffing issues continue to be critical and to draw considerable attention. Well, that's the good news. Some background. Let me give you this first. Nursing homes are mainly about care for women, by women, many of whom are racialized and are newcomers. Care has long relied on the undervaluing of their work and attaching low value for those for whom they provide care, taking advantage of their limited alternatives. Much of the work has been defined as unskilled, although if you spend hours observing their work as we have, it quickly becomes obvious that even what seems like a simple task, for instance, assisting a resident to eat, requires considerable skill when a resident has no teeth, cannot easily swallow and thus risks choking, has no appetite, and has dementia that makes them actively resist eating, spit out food, and often scream. Over a decade ago, our survey data indicated that Canadian staff were more than 6 times as likely as their Nordic partners to experience violence on a more or less daily basis. Staff in both countries dealt with very similar resident population, but more Nordic staff had full-time jobs. There were more staff, the staff had more autonomy, and their teamwork allowed them to figure out strategies to, for example, encourage Mr. Smith not only to eat, but also to enjoy it without screaming. Since that study, work in Canada has become more precarious and staffing levels have failed to keep up with the increasing complexity of resident needs. Many work part-time and overtime in multiple workplaces in search of a living wage. As the Ontario staffing study conducted before the pandemic showed, a quarter of the personal support workers who do the bulk of the work in long-term care, those who had more than 2 years of experience, leave every year, and PSWs make up the majority, as I just said. Moreover, training was not keeping up with the complexity of care needs, often leaving workers feeling inadequate, as did the failure to have enough time to apply the skills they already have. During the pandemic, homes relying on the lowest possible number of staff, on as many low-paid, part-time, and casual staff as possible, and homes that had often worked short of their usual low minimum number of staff, suddenly found they had impossible numbers. Many staff stayed home because they were ill, because they had to look after their children who were out of school and daycare, because they were afraid, and because jobs that were already highly stressful with heavy workloads became unbearable. The good news is that the government took some action. The federal government stepped in to provide money to increase the low pay and attract workers in the short term. In Ontario, the government provided some continuing increase in pay and restricted workers to one workplace, providing some temporary compensation for doing so. It increased spaces in training programs and sped up entry for workers educated outside Canada. It also passed long-delayed legislation to set a minimum of 4 hours of direct nursing care per resident per day, something to celebrate indeed. The bad news is that, while this is better than in the past, these minimums were set out in the US well over a decade ago when residents had less complex care needs. Today, Harrington and others, Charlene Harrington, who's on our research team, are recommending at least 6 hours of care. Moreover, the 4 hours in Ontario are a target, with 15 minutes added this year, and the 4 hours the target for 2025. So many currently in nursing homes will not live to see the day, even if the target is realized. And the specified enforcement of these targets is quite weak. At the same time, little has been done to ensure that the majority of staff have full-time jobs, as the research, the Ontario Staffing Study, and the Long-Term Care Commission made clear is central to continuity of care and to retaining staff. Indeed, virtually nothing has been done about the other conditions of work that make care possible and keep people in the jobs. As we have long argued in our research, the conditions of work are the conditions of care, and COVID made it clear how bad those conditions too often are. According to recent data from StatsCan, COVID has a significant impact on extending work hours, decreasing vacation time, and changing methods of doing work. And workers are responding with their feet, leaving or planning to do so. Now, it was also good news that COVID coverage further exposed how families are critical to care, my second issue and a topic of one of our current research projects, as you heard from Jennifer. When families and volunteers were locked out to prevent infection spread, the gaps in the care provided by staff became even more obvious, as did the work families provided to fill those gaps. And it became obvious that loneliness can kill, emphasizing how social care must be part of paid work. The media focused more on how the absences of families meant loss of personal contact and social support, critical to care, of course. But as we have seen in our research, families, and by family we usually mean women, provide so much more additional care, helping residents eat, go to the toilet, brush their teeth, wash their hair, walk, talk, and dress, to name only some of the labor they do for relatives and often for other residents as well, who are not related to them. And families are essential advocates. COVID made families even more vocal in their advocacy. And as we have shown in our research, COVID prompted families to become more involved in family councils and prompted those councils to be more involved in a broader range of issues such as challenging government action or non-action. It's unlikely that these unpaid workers will be blocked from entry in the future, and some of the lessons about means for communication will endure. I should also add that residents too often provide unpaid care, work that was prevented by isolation strategies, and it may be so again if we have more lockdowns. The bad news is that the strategies introduced are more about allowing families in to do the work rather than about recognizing how little choice they have about doing the work, given the gaps in care. In Sweden, we did not see families provided this kind of care. Swedish workers told us it was their job to ensure paid staff provided the full range of care, including social care, and that families and volunteers should not be expected to do this work, although staff certainly encouraged family visits and other forms of involvement. Now, my final issue is mainly about bad news. The government has largely ignored the evidence produced by the Toronto Star, the Health Coalitions, and many academic research on how the death rates were significantly higher in Ontario for for-profit homes and lowest in government ones. Earlier evidence demonstrated a pattern of poor quality of care measured by such things as bed sores and transfers to hospitals, lower staffing levels, and poorer working conditions. All evidence heard by the Long-Term Care Commission as well. Some of this was blamed on the 4-person rooms in for-profit homes, but we need to ask why they had so many of those rooms. Excuse me. Our research looking at the response to scandals in our countries found that most scandals were in for-profit homes. The common response in North America was to introduce new regulations that primarily focused on staff and residents and introduced more record keeping by staff, but introduced few, if any, structural changes like higher staffing levels or challenges to ownership. Instead of listening to the outcry, Ontario is funding new beds. Increasing supply is critical to addressing the very long waiting lists, but the majority of those new beds will be in for-profit homes, including in one home that the military rescued. In sharp contrast, Saskatchewan responded to the evidence and has taken over the operation of 5 for-profit extended care homes in their province. Obviously, it can be done. In any case, a bed is just a bed without staff, And to attract and keep staff, we need better conditions. And these are much more likely in publicly owned nursing homes. Now, I could go on talking at length about other issues that have been exposed by COVID, like the physical structure of homes and other issues that have received too little attention, like meals, clothes, and laundry, identifying the good and bad news there. But let me sum up by saying that COVID has put nursing homes on the agenda, and we need to make sure that they stay there. It has taught us that we need appropriate, enforceable, funded strategies to address conditions for staff and families so they can safely and effectively provide all the care that makes life worth living and the work worth doing. And we need to get the profit out of care. Now, there's no single right way to do this, but there are many promising practices we have identified in our work in the 6 countries, practices that go well beyond staffing, families, and ownership to talk about issues such as food, clothes, laundry, and integration with the community. If you could put up the slide now, you can see that you can read about these promising practices in our 4 small books. Christine, sorry, maybe I wasn't clear enough. If you could put up the slide, that would be good. These small books can be downloaded without cost or in our many other publications listed on our website. And I thought we were going to have a slide, but maybe we can put that slide up later if it doesn't appear now. Anyway, thank you. And I look forward to hearing your questions later.
Thank you, Dr. Armstrong, for your insightful presentation. And the slide did appear. You may not have seen it in the mode that you were viewing in. So that's wonderful. And yes, we should share that information as well at the end of the presentation.
Great. Thank you. That's why I couldn't.
No, that's wonderful. A reminder to our audience, feel free to submit your questions by using the Q&A button at the bottom of Zoom at any time in advance of the Q&A session, which will be held following all 3 of the lectures that we're having this morning. And now I'd like to introduce our next speaker. Dr. Farah Ahmad is a professor in York's School of Health Policy and Management in the Faculty of Health. She is a healthcare researcher who holds an equity lens. Dr. Ahmad conducts community-engaged mixed method research with a focus on primary care settings, psychosocial health, vulnerable communities, and e-health innovations. She has held multiple awards, including the CIHR New Investigator in Primary Healthcare and the Early Research Award from the Ministry of Economic Development and Innovation. Dr. Ahmad teaches courses in e-health, health promotion, migration and health, and research methods. Welcome, Dr. Ahmad.
Thank you. This is my pleasure today to present my research work and my insights about the e-health and inequities that emerged during COVID-19. I would like to walk you through some of the key aspects that have emerged and share my slides with everyone. Okay. First, I would like to begin by talking around the concept of health. Many of you would recall that in 1948, World Health Organization defined health as a state of physical, mental, and social well-being, and not merely the absence of disease or infirmity. This was a groundbreaking definition at that time because it challenged the hegemony of a medical definition of health, which exclusively focused on physical aspects of health, the body health. Following this, many groundbreaking scholarly work started to emerge. And one milestone work in Canada is the health field concept by Leland in 1974. And this work, was a platform for what we now know social determinants of health. Through that framework, we have learned the root causes of health inequities. And health inequity, refers to those health inequalities which are avoidable, unfair, and unjust. They refer to the social stratification and many other dimensions. And there is a lot of interdisciplinary work that has emerged, using that lens. However, when we take a very high level view on the status of health research, we still find that there is a big focus on physical health. And some focus has started to emerge on mental health over the last 1 decade or so. And the social well-being is just hanging on by fingernails. What COVID-19 has done is to put more attention of researchers, policymakers, and practitioners to mental health and social well-being, because the pandemic, had a big impact on many dimensions, including mental health and the social well-being of the population. We know that in Canada, we lost more than 46,000 people to COVID-19, and the impact was disproportionate. For example, in terms of the life lost, most of the impact was for seniors. There was a disproportionate impact. And when it comes to the number of cases, we notice that women or females in the age group of 20 to 59, they experience higher number of incidents compared to males. Continuing on the thread of disproportionate impacts, when we think about racialized populations, it is hard to find national level studies, and which is an ongoing debate that Canada doesn't collect information by race or ethnicity in the administrative processes during hospital care, primary care, as a routine. This data is not collected. However, in some regions, there was a specific effort made to collect data by race. For example, Toronto Public Health units in Ontario collected that data, and they found that racialized groups, they experienced higher numbers of COVID-19, hospitalization rates, ICU admissions, and also fertility rates. So there is an ongoing impact on the racialized groups and many other vulnerable groups. When it comes to the mental health, we understand through large-scale studies collected by Health Canada, there was a disproportionate effect by gender, by age group, by also among Indigenous communities, frontline workers, and those who had traumatic experiences in the past. Still, there are many vulnerable groups which are left out, and we do not really understand the impact on their mental well-being during COVID-19. Therefore, looking at this whole context, I would argue that we need to do much more research work, at the intersection of COVID-19, vulnerable groups, and mental health. One big reason is that, at the baseline, these vulnerable groups have limited resources. They have resource constraints, which are, social resources, material resources, or their physical resources. And during COVID-19, we can see that they experience a large number of COVID-19 cases, fatality, and many other consequences. So there is a cumulative effect, and it has culminated in a higher burden of mental stressors for them, and even, probably, clinical conditions, which we call as mental disorders. At the same time, in Canada, the funding for mental health is limited to psychiatrist visits or care. So there is a gap there, and at the same time, the demand is high and probably is going to remain high for a couple of years because mental health impacts are long-term impacts. And they can have consequences beyond the individual. They can impact their families, their social well-being, their work, and their careers as well. So to understand how COVID-19 actually, was experienced, and we can do more research. During COVID-19, also there was a larger focus on e-health or virtual mental health care delivery because we experienced social distancing, lockdowns, and the healthcare system adjusted itself. It responded to the environment by delivering healthcare virtually. However, the question remains that how these e-health virtual delivery solutions were experienced among vulnerable communities. Were they experienced the same way as the mainstream populations during COVID-19? Although we do not have large-scale studies, but our group started to work on that. And we've specifically looked at the experience of refugee communities during COVID-19 in relation to virtual mental health care access. It was an interdisciplinary team with lots of knowledge users and collaborators conducted in 4 provinces, Ontario, British Columbia, Alberta, and Quebec, funded by the Ministry of Health and CIHR, Canadian Institutes for Health Research. We followed a mixed method approach where we first developed advisory committees with the newcomers and also providers. And then we conducted key informant interviews and qualitative interviews with the refugee community. And we engaged with the providers through key informant interviews and a survey. I would like to share today more of our understanding through the qualitative interviews. Overall, when the providers were asked about, how their delivery for mental health care has changed during COVID-19, we learned that before the pandemic, a lot of that was through in-person visits. And during the pandemic, in-person visits were almost negligible. And the reasons we know were the public health, guidelines, social distancing, lockdowns. So everything almost changed to the virtual mental health care. And in the qualitative interviews, we learned multiple themes. And these interviews were conducted in different languages because we were approaching refugees. As you know, these populations are forced out of their countries under unusual circumstances. And they arrive in Canada under emergency situations through humanitarian policies we have to accept refugees. So multiple languages were used and peer interviewers were involved. And when we analyzed the data, we learned so many things. A big thing was approachability, their ease to access services. First, we learned that newcomers, they learn about mental health services through formal and informal networks. And during COVID-19, those networks were shrunk. So they relied much more on the websites. And the providers also tried to disseminate knowledge about what services are available, where are they available through websites, social media, and having live online group sessions. So the whole delivery system was changing. And you can imagine a newcomer with limited language skills, not a big know-how of the system, and then a big social stigma for mental health. it was definitely a challenge. People who were not closer to these resources were probably left behind. Another theme was the acceptability of virtual mental health care by thinking about social factors. And key finding was that both providers and newcomers, they told us that it was not ideal, but at least virtual mental health care was available to them. The reasons were that, some participants from the newcomer community said that it was contradictory to their oral tradition. Some were not comfortable with the use of camera. Privacy was an ongoing issue through virtual, mental health care. And we all know how we also sometimes felt, uncomfortable using those cameras during our workspace times. Many refugees receive these services in presence of interpreters. And the inclusion of interpreters during virtual mental health care delivery was giving a mixed, findings. Sometimes the participants from the newcomer community felt that it added more privacy rather than having interpreters, during the in-person interviews or sessions. However, they experienced technological difficulties. And those who had a more severe history of trauma, and they felt that presence of interpreters was not helpful for them. And in cases of domestic violence, it was a bigger issue because these members who were interpreters, are sometimes closer to the community. It's a small community, and the clients, the newcomers, were concerned that their privacy will be harmed if they discuss these sensitive issues. And in cases of domestic violence, we know privacy was a big issue. Another aspect was about availability of devices and what accommodations were provided by the providers and agencies. First of all, the good part about virtual mental health care was that it was bridging the challenge of distance. It saved time, cost, and travel inconvenience for the newcomers. However, newcomers felt that it was a challenge to negotiate about the modality of virtual care because many of them were not familiar with the, video cameras, the use of those technologies, and it added further challenge for them. And they felt there was no choice for them. Whatever was offered, they had to accept it. Although providers were trying to offer some accommodations, providers also experience a dilemma that what type of modality should they prefer? Should they worry about the preferences of the newcomer refugees and their technical skills, or should they follow the regulations provided by the professional bodies about the privacy and security of data, and what platform gives them that facility? The flexibility of the schedule was a big issue among newcomers. They wanted to have more flexibility, but at the same time, providers were struggling with the work-personal life balance because some of those virtual mental health care visits were delivered from home. Overall, there were challenges around building therapeutic relationships, because there were home distractions and less engagement between, the newcomers using those, visits and the providers. Providers felt that they could not capture the body language, which is important when you are talking about mental health, to understand whether continuing the conversation is a better way or discontinuing and giving them another opportunity. So some of the providers came up with a different strategy. They first scheduled in-person visits, and then the rest of the visits were through virtual care. Cost of technology was a big barrier for the newcomers. They couldn't afford the devices, the data plans, and sometimes the internet was not reliable. So some of the providers and their agencies provided them with subsidies for data plans or donated phones. Another theme was about appropriateness of the quality of care and fit with the client needs. So providers and the newcomers, both of them, felt that, in-person care is a better choice. However, during the pandemic, they were doing whatever was available. And the reason for in-person care preference was stemming from the communication complications they experienced during virtual modalities. Some of those, newcomers and the refugees, they had language challenges, and sometimes they felt that they were talking in a louder voice, and they worried about the providers, perceiving them as if they were yelling. And as we talked about, the presence of interpreters was another, challenge for them to feel comfortable and talk about their histories of trauma, the mental health concerns they have. And privacy was an ongoing issue because, they were living in small spaces with larger families, and they could not talk about some of the mental health concerns, the issues of domestic violence and other stressors in a private manner. So moving forward, I would conclude that, e-health for mental health needs to apply an enhanced equity lens for client-centered care, because one size does not fit all. When we are talking about vulnerable communities like refugees, they would be better served by engaging them in the development of e-health programs and identifying hybrid models. Because in this research, we learned that they have, and it is consistent with the pre-existing research, that they experience financial barriers. Digital literacy is an ongoing barrier for virtual mental health care. We want to have those models that would offer them comfort, privacy, and safety, because mental health is a very sensitive topic. And in the larger society, there is stigma, and some communities have higher level of stigma around mental health. To have effective, high quality care, we need to develop models which would build, trustworthy therapeutic relationships. And needless to say, we need to have ongoing support and training for providers on the cultural and social context of the communities they are serving, especially when they are coming from vulnerable context. On a big scale, this type of e-health innovation for mental health purposes and for vulnerable communities needs to have sustainable funding. Right now in Canada, we have more like a, projectism approach, where smaller projects are funded, and when it comes to upscale those approaches, there's an ongoing challenge about funding. The other side is about the funding of the mental health services at the policy level, because there are so many ways to support, people. We have, counseling available. We have social workers, many approaches. However, currently, these are psychiatric services and visits which are funded. So we need to shift the lens about mental health care. Think about the well-being of the people, much before they land on the clinical side and they have to see a psychiatrist. We have to think broadly, what is mental health, what is mental well-being, and also the root causes of those stressors for mental health. How can we fix those root causes, the inequities they experience on the social side, on the material side? How can we create a better safety net so that people are not falling through cracks and these mental stressors culminate into mental disorders? So a lot of questions are remaining, and we need to work in interdisciplinary teams to bridge those gaps between research and practice. Now I would like to conclude. Thank you for your participation, and I look forward to your questions for the later period. Thank you.
Thank you, Professor Ahmad, for sharing your research outcomes with us. This has been really enlightening. And now I would like to welcome our final speaker, Dr. Skye Fitzpatrick. Dr. Fitzpatrick completed her PhD in 2018 at Toronto Metropolitan University, where she studied the nature and treatment of borderline personality disorder, BPD, with a special focus on dialectical behavior therapy. Following graduate school, she completed her pre-doctoral internship in Seattle at the University of Washington, where she did research and received clinical training in the treatment of post-traumatic stress disorder, PTSD, which often co-occurs with BPD, borderline personality disorder. Her current research focuses on identifying ways to optimize, expedite, and broaden access to BPD and PTSD treatments on their own and as they co-occur. In the interest of making certain methods of intervention more widely available, Dr. Fitzpatrick has been studying and developing online, remotely delivered self-help tools for individuals and couples living with the effects of PTSD. Professor Fitzpatrick, thank you for joining us. I'll turn it over to you.
Thank you so much for having me, and thank you to the audience for coming on a beautiful autumnal day, at least if you're in Toronto. So you probably had many ways to spend your Saturday morning. So thanks for being with us. Okay, I am going to get going, and I'm aware I have a time limit, so I'm gonna kind of keep my eye on the time at the same time. I want to talk a little bit about some work that myself and my colleagues have been doing lately to try and figure out ways to treat PTSD that's related to COVID, particularly among frontline workers, but also in other people who are experiencing PTSD symptoms from the pandemic. So I'll just start by contextualizing who I am. I don't think I actually have to say much more. Thank you so much for that lovely bio. But yes, I do study ways to optimize treatments for PTSD. One of the things that I want to plug early, though, is the relationship between PTSD and our social relationships. And that PTSD is not really just an individual problem, and we need to think about treating it as a non-individual problem as well as a relationship problem. And then I'm going to talk a little bit about some of the methods that we've been developing to treat it. So the problem, you've heard this a little from some of my colleagues and co-presenters today, but mental health conditions have risen significantly in response to the COVID-19 pandemic. We saw this coming as psychologists at the beginning of the pandemic. Post-traumatic stress disorder was the most significant mental health condition following other pandemics in the past. So it's not surprising to me that a third of young adults reported clinically elevated levels of post-traumatic stress in April and May. And we know that first responders, military members, veterans, and also healthcare workers are particularly vulnerable to PTSD, more so than other people in the population. In fact, healthcare workers have higher rates of PTSD than those who actually contract COVID-19. Up to a third of healthcare workers have clinically significant PTSD symptoms, as in a notably high amount of PTSD symptoms. So do people who have survived the virus itself. So in the ICU, the intensive care unit in hospitals, about a fifth of ICU survivors have PTSD symptoms, and even more of their family members have PTSD symptoms. I'm sure many of us have been in the either in the ICU or knowing people who are in the ICU or with people as they go through that experience, and it can be very, very traumatic and complicated for all of our mental health and well-being. So let me just take a step back for a second and just talk like big picture about what PTSD actually is, like what I mean when I say PTSD. PTSD is a mental health condition. It's one of the few mental health conditions where we actually know the cause in a more definitive sense. And the cause is exposure to some kind of traumatic event or stressor. And following exposure to a traumatic event, there's 4 groups of symptoms people typically experience when they have PTSD. The first is hyperarousal. That's that little quadrant that's shown up on my slide there, which means that your mind or body are hyper or overactivated. They're revving too high. So this involves things like feeling on guard all the time, feeling jumpy, feeling more irritable than usual, having difficulty sleeping. Another group of symptoms is called the avoidance symptoms. When people are constantly in a state of hyperarousal and they feel really distressed when they're reminded of the trauma, they start to avoid things that remind them of the trauma, even objectively safe things. So things like smells, sounds that remind them of the traumatic experience, talking about it, being around people who remind them of it. This can lead to the next group of symptoms, which is changes in thoughts and mood. So following traumatic event exposure, folks with PTSD often have really negative beliefs about the trauma. They might blame themselves erroneously. They might blame the world in ways that are inaccurate. I mean, sometimes that is accurate, sometimes it's not accurate. They also can experience persistent negative emotions like this sense of hopelessness, flatness, disconnection from things around them, less positive emotions, less kind of connection and engagement with their life that they used to have. And the last group of symptoms is called the intrusive symptoms, which are kind of your classic PTSD symptoms. These are called intrusive because they involve the trauma intruding on your life. So nightmares, flashbacks, reminders of the traumatic event happening out of nowhere, and high levels of distress that happens when people are reminded of the event. So when people have symptoms from all of these clusters following a traumatic experience, and they've lasted for at least a month, we call that PTSD. But the thing is that PTSD doesn't just affect the person who's living with it, it affects relationships too. People who have a lot of hyperarousal often get into fights with their intimate partners. Partners might feel controlled all of a sudden or on the receiving end of more anger. Partners or loved ones or family members often start to kind of help people with PTSD avoid because they think they're helping them reduce their distress. So if somebody has PTSD from a car accident, the loved one or family member might be the one that starts to drive everywhere because it's too upsetting for the person with PTSD to drive. They might be the one to sit with their back to the door of a restaurant so that the person with PTSD can sit with their back to the wall and kind of scan the restaurant. All kinds of ways that loved ones get pulled into avoidance. And of course, with the changes in thoughts and mood, people with PTSD often have a feeling of disconnection, and that can really affect your relationships. So this is a little bit of a busy slide, but just to say, one of the questions is most of us will experience a trauma at some point in our life. We've all kind of been through the trauma of COVID-19, but most of us don't have PTSD. So the question is, who is more or less likely to get PTSD following a trauma? And most studies come back and tell us that social support is one of the strongest predictors. The stronger our relationships, the more protected we are from developing PTSD in the wake of a traumatic experience. So that tells us that there's something about our relationships that are really, really important in developing and recovering from PTSD. So we started to think, myself and my colleagues, actually for many years, people before me started to think that maybe it's important to treat PTSD and relationships at the same time through what's called a conjoint therapy for PTSD, bringing somebody with PTSD and their loved one, like a partner, a spouse, into the therapy room at the same time. And we think that this is a good idea because PTSD is, as I said, highly associated with relationship problems, but our existing evidence-based therapies for PTSD don't tend to improve relationship functioning. We also know that when people's relationships are not very strong, they tend to do worse in our PTSD treatments. So probably targeting the relationships can help us improve our PTSD outcomes. But the main reason to think about treating PTSD and relationships at the same time is because you can get a potential for 3-for-1. You can treat PTSD, relationship functioning, and partner or significant other mental health and well-being all at the same time in one therapy. And this is particularly relevant to something like a COVID-related trauma, where a lot of folks are going through this together. They are both experiencing stressors. They are both affected by the traumatic event. So they might as well both be in the room. So these conjoint therapies for PTSD have been developed, and they do work to both improve PTSD and improve relationship functioning at the same time. But the problem is there's barriers to getting them. Of course, these treatments involve highly trained providers. They tend to be concentrated in cities. Wait lists are extremely long to access them. People who are geographically in more remote areas have a very hard time accessing these evidence-based psychotherapies. There's stigma. A lot of people don't feel comfortable coming into a mental health office. And then the pandemic made all of this much worse. All of a sudden, our face-to-face methods of doing therapy that we've been doing for many years were completely turned upside down. And all of a sudden we couldn't reach people anymore in the ways that we used to. Our healthcare system became even more strained. And so we needed to develop light touch, low resource, and broadly accessible methods of treating PTSD and enhancing relationship functioning at the same time. And that is the vantage point from which myself and my colleagues developed Couple Hopes. Couple Hopes is an acronym. HOPES it stands for Helping Overcome PTSD and Enhancing Satisfaction. And it is an online therapy that is designed, an online intervention, I should say, that is designed to target PTSD and relationship functioning at the same time for couples wherein one member has PTSD, including couples who have that PTSD from the pandemic. Couple Hopes is designed to be low resource so that it does not require a lot of burden from our already stretched healthcare systems and does not require a high level of expertise to administer. PhD level psychologists are very, very rare. They're hard to come by, and they're not very effective in terms of being the front line of mental health care because they're so specialized, rare, and frankly, expensive to access. So this is more of a self-help intervention that has coaches that go alongside it to help people engage with the intervention. But those coaches are what we call paraprofessional, as in they are not licensed mental health care providers, which means that they can be involved in administering the intervention at a lower cost, and it can scale more easily because there's more people who can do that. So Couple Hopes involves interactive modules with video content that disseminates key information about skills to recover from PTSD and enhance relationships, interactive practice exercises, and an easy to navigate online platform. This is kind of an example, if you went to our website, couplehopes.com, which you are welcome to do, of kind of what you would see, some of the sort of branding and look of Couple Hopes. One thing I will say as a psychologist and scientist, this was a really enriching experience because I had to work with people in making Couple Hopes that are far outside of my area of expertise, people who are experts in web design, gamification, where they know how to make a program that people actually want to engage with on the computer, user interface on a computer, these things that I have no expertise in, but all of a sudden became really important to making our program actually effective for people. So when you log into Couple Hopes, you might see something like this. There's modules that you progressively unlock with your partner as you go through it. And those people from those other expertise, those more digital expertise, gave me a lot of fascinating feedback to make sure that this program is engaging and accessible. So there's online message centers where you can message with your coach. There's progress bars that kind of show you your progress through the program. That's kind of an element of gamification that creates like a motivation to continue with the program. You unlock modules as you go. Even things about like, where are the buttons that help people progress? A lot of us, unless you work in that field, we don't think about that kind of thing, but you notice it when it's wrong, when you're working on a website that is poorly designed. So this was a very interdisciplinary effort and build. So now the next question, of course, is like, does it work? And I think that's a great question. I too want to know if it works. So I have a little information I'll present on that. All involving kind of frontline workers that was conducted through the pandemic. So the first study was a case series of 10 couples when one member was a military member, veteran, or first responder with elevated PTSD symptoms. And the next study was a trial of 17 couples, so just a bigger study with the same criteria. So in our first study, we administered Couple Hopes to this group and we measured PTSD symptoms in the military member, the veteran, and the first responder. And what you basically are seeing here in our graph is this is statistically what we call a large effect size. So this is a significant decrease. We would call it clinically significant from pre to post intervention, meaning that the PTSD symptoms changed in a meaningfully large way. In terms of relationship satisfaction, this is where we start to see some interesting effects. So the people with PTSD symptoms didn't experience changes in relationship satisfaction. I would note that their satisfaction is also already quite high. So sometimes when you have people coming in pretty good already, it's hard to make it like better, but their partners did. So from the beginning to end of Couple Hopes, partners who went through the program with them reported increases in relationship satisfaction. The next study, we see the same kind of large effect on PTSD, but we don't see a significant change from the end of Couple Hopes to a follow-up that was done 1 month later, which is a good thing. That tells us that the improvements we saw from Couple Hopes were maintained. People didn't bounce back up again once they had finished the intervention. What we see in terms of relationship satisfaction, so the lighter blue is the folks with PTSD symptoms. We do see an increase in relationship satisfaction, but it's not statistically significant. And then it looks like from the end of Couple Hopes to the follow-up, they're worsening. But if you compare their follow-up score to their pre-Couple Hopes score, it's actually the same. So basically what's happening here is they're kind of like, they had a little bump at the end of Couple Hopes, and then they kind of went back down to their baseline. The partners, on the other hand, experienced improvements from Couple Hopes after doing Couple Hopes that was sustained over the follow-up period. So they got to keep their gains. So that's good news. We did not just see improvements in those areas. We've measured other kinds of things that we saw improvements in as well, including conflict, the extent to which folks with PTSD have depression, which often occurs with PTSD, and partners accommodation. So accommodation is that idea I mentioned earlier of working around avoidance, all these things these partners are doing to help the person with PTSD avoid trauma-related distress. It usually does decrease folks with PTSD's distress in the short term, but it can be really hard on the partner, and in the long term, it actually contributes to keeping PTSD going. I'm happy to talk about why that is during the question or answer period, but we see big effects on partners' accommodation decreasing, which is a good sign. So this is very exciting because now Couple Hopes is built and it is low cost. It's very easy to scale. Anybody with a computer and internet access can access it. And it doesn't require highly trained professionals, which are very difficult to access. I think Dr. Ahmed has made some excellent points about how we can't assume digital literacy. We can't assume that everyone knows how to interact with the computer and the program. And certainly all of those kind of experts in gamification have helped us try and optimize that. But it does suggest that we're going to need to start to study, who is this working for? Who is this not working for? Over time, because there is no, one size fits all. But our next step is further testing. So one of our next questions was, okay, we know it works better than just the way people were before. It improves people from where they were at, but does it work better than just simply measuring PTSD and not doing anything? Does it work for people who are on the front lines of the pandemic who specifically have PTSD from COVID? So we had tested it in these frontline workers, but we hadn't tested it in folks who have PTSD related to COVID specifically, people who have witnessed deaths from COVID or had their own life-threatening experiences. And that's where we're at right now. We are conducting kind of 2 randomized controlled trials that are exactly the same, but in 2 different groups of people at once, where basically we're bringing in folks who are either frontline workers who can have any kind of trauma. So it doesn't need to be related to COVID, it could be, but it doesn't need to be, could be just related to other like line of work or completely unrelated to their work. So frontline workers, military members, veterans, and first responders, and healthcare workers with PTSD. And we're also recruiting folks who have PTSD related to COVID, but could have any occupation or no occupation. So these are folks who maybe experience things in long-term care homes, maybe who are working in them, family members, people who experienced COVID themselves, witness this in somebody they love. Anybody who has elevated PTSD symptoms related to COVID is also eligible. And so these are kind of two separate groups that are kind of going through their own versions of the same trial. And once we recruit them, we randomize them to either receive Couple Hopes right away or to wait and just complete measures of PTSD and relationship satisfaction. And then when the measurement period is over, we will then give them access to Couple Hopes. So this will tell us if Couple Hopes is more effective than just monitoring your PTSD symptoms, which is an important next step of testing. So ultimately, I think we're excited about where this is going. There's so much more to do. This is really, really early days. But I really look forward to hearing your questions and comments and to continuing this line of work. So thank you so much for listening to me.
Thank you so much, Dr. Fitzpatrick, for that incredible presentation. And I loved your slides. I loved the mountains. I was not so keen on that precarious looking bridge that overlooked the mountains, but my palms were sweating a bit. Wonderful presentation. And thank you to all of our speakers this morning. So now we're going to begin our Q&A portion of today's event. So I'd like to invite all of our panelists back for the discussion. Please turn your cameras and sound on. And the audience, as we've mentioned before, you may submit your questions using the Q&A function at the bottom of your screen. And for guests who are joining from Facebook, questions can be submitted via the comment section. Okay, and so we have a question that I will read out. Dr. Armstrong, this is for you. We need to have major changes to long-term care in Ontario. Are you aware of groups that are engaging with the government and advocating for these changes?
The answer is yes. It's happening on many, many fronts. There are health coalitions. There's the Canadian Health Coalition, and every province and territory has one, and they have local units, and they've been doing, in Ontario especially, they've been doing really incredible work gathering information. Right now, the government isn't providing us with detailed information on who has COVID and increases in COVID, and the health coalitions have been collecting that information to provide us, for example. So also, I get asked all the time to speak at a whole range of organizations that are doing stuff on this. University women's clubs, seniors or women's seniors organizations across Canada. There are multiple organizations. If you Google them, I'm happy to connect you with the health coalitions. I'm on the board of the Canadian Health Coalition, and there is some other action happening now. I'm on what's called the Technical Committee of the Health Standards Organization, which is 35 people who are advising the government, federal government in this case, on new standards for long-term care. And those have been out for a while, but there'll be new standards released in January. I'm really hoping people will read them and respond to them and assess them. And one of the best ways we can do this is to keep ourselves informed about what is happening. I think in terms of aging, it's extraordinary. We ask people what they want to be when they grow up. We don't ask people about what they want to do when they grow old. Mm-hmm. And I think that we need to start asking that question. And to go back to Skye's great presentation, we're certainly seeing extraordinary amounts of PTSD among healthcare workers in long-term care, especially where the death rates have been so high. But it's not new either. And I was thinking of, Skye, of your research and this new strategy you're talking about. In long-term care, the precarious employment that I was talking about has made that kind of mutual support that you are talking about in terms of couples virtually impossible, because the turnover is so high, people have part-time jobs, they don't work in teams, they had a really rigid division of labor, they spend half their time documenting, you know, how many stools there were, as opposed to figuring out how to make sure people's digestive systems work. You know, that I think that there's a lot to learn in terms of the work organization from the kind of research you're doing as well.
Can I'd love to respond. I mean, thank you for that comment. I mean, I was thinking about this with respect to your presentation as well, because I don't want to undermine the importance of mental health. Obviously, I am a big advocate of that. But, you know, one thing I often think about with folks who are working on these front lines in long-term care homes, like nurses, people who are dealing with the ER crisis right now, they have these really high mental health conditions. And I often think about like, okay, what's my role? Where's the role of my research in this? And I think it's really important, but at the same time, it's kind of like, sometimes it feels a little like, oh, I'm offering an individual solution to a problem that is really driven by a system that's not appreciating these workers and not putting them in conditions that are conducive to their mental health. And so sometimes I wonder if like, oh, if like, you know, employers rolled out Couple Hopes and said, here's Couple Hopes for all of you. It's like, that's great, but they actually need, you know, more work stability first, or, you know, wages that are more conducive to cost of living. You know, I think about those things and I just wonder, how you think about that intersection and that kind of prioritization of needs.
That's partly why we talk about the conditions of work or the conditions of care. And it's related, of course, as well to Farah's presentation and her research, that unless we do something about the structural aspects, you can give people individual therapy or individual strategies all you want. But if you don't make enough to eat, if you have to work at 4 different workplaces, if you don't know who you're working with, and for instance, the load, what we hear a lot about from the small numbers of full-time staff we have in these in long-term care and increasingly in hospitals as well, is that they bring in all of these casual agency part-time workers, which is something some women are moving to because they just can't work full-time as well. So these 2 things are happening because they work so hard, that they can't build relationships with those people. They don't know who that person is. You have one agency nurse today and there's a different one tomorrow. And both sides of that equation are in trouble in terms of getting kind of satisfaction and feeling like you're doing a decent job, which is really problematic. And all of the questions that Farah was raising are applicable as well to the increasing number of people who are working, newcomers who are in long-term care, who have another layer of issues added to those.
Right. Yeah, I would absolutely add to that. I mean, you know, the recent news from Statistics Canada that 25% of Canadians are immigrants, meaning, you know, not born in Canada. We're not talking about children of immigrants. So if 25% are immigrants, and, you know, we are often receiving them as in their adult years, majority of them, to contribute, you know, in the economy, because it's a economic policy that Canada has. So what is going to happen when they turn older, right? We will see more and more of diversity in long-term care. And some of those cultures, they are very family oriented. You know, what would happen that when there is a cultural clash between, you know, first generation, second generation, how would it affect their mental health? You know, because so that's a big piece. You know, I see, you know, we are getting immigrants for sure, but there could be a, you know, are we ready at the system level, at the policy level, you know, for their, you know, later years?
Right. Wow.
Well, Ito Peng, new big research project at U of T that various people from York are also connected to, is very much looking at those kinds of questions. And it applies to those issues you're raising apply to both the people who, well, I shouldn't say both. They apply to the residents in long-term care. They apply to the families of the residents in long-term care, and they apply to the people who work in long-term care. And to go back to what Skye was saying, absolutely to the structural conditions under which those happen too. And as both of you have said, there's not one size fits all. There's not one correct strategy for all of these. There are multiple strategies, which is why we talk about promising practices and not
the answer.
Yeah. Yes, that's right.
It's striking me, and my understanding is we don't have a question coming in, which is why but please interrupt me if there's a question I should be answering. But maybe just to say, it's striking me that, one of the things we know about trauma is there are some factors around the experience of trauma itself that can predict the development of PTSD. So if you are not, for example, there's been some research that suggests that getting like adequate pain management is in a hospital after a traumatic injury is associated with like lower rates of PTSD. And we don't know why that is, if it's like actually a neural effect or it's just like having your pain well managed makes the experience less traumatic. But it just makes me think about having a healthcare worker who is consistent, who is able to show up, who is able to provide for you in a traumatic moment because they are in an adequate working condition, probably reduces the rate of that person developing PTSD, which probably in turn reduces the costs. Like PTSD is also costly on healthcare systems as well. So it's just that, you can really see the downstream effects.
Well, if I could just add one thing, we do know from so much of the research in long-term care, if you know the residents, especially when the majority have some form of dementia, that they are much less likely to have the behaviors that are described, because you know that Mrs. Smith gets really upset at green peas, and that you know their history, the kinds of things that trigger that trauma reaction, right? But you can't do that if you've been working on the job for this is the first day on this floor, and then you're not going to be there anymore.
This is great discussion and wonderful to see, how everything is coming together. I'm going to go to a question that was posed by our audience, and this one is for Dr. Ahmed. And the question is, I understand that in Ontario, compensation for physicians for virtual visits has changed. And what is the expected health outcome of this action?
Yes, so there were billing changes, and and they could charge for the virtual visits, and still, there is they haven't gone back fully to the only being able to charge in person. They are mixed results, and I think much more research is needed. But generally, some providers are keeping the virtual visits, even the phone calls, for simple rather simple, like follow-up, sharing the results, re-prescribing a medication, and they are keeping the in-person for more complex new conditions, comorbid. So I think we are seeing more flexibility among the providers, and because they have to follow their guidelines, offer the standard of care that the patient needs. So we are seeing a lot of that on the primary care side. Definitely more flexibility among the providers, but the question still remains whether some of the sensitive issues, would they come up, because I know I have worked in the area of partner violence, in area of mental health, that sometimes those are side issues, that a patient's main complaint is lack of sleep, body fatigue, but actually they are experiencing depression, or they are having, conflicts at home. that is putting a lot of stress. Some cultures present their depression in a psychosomatic manner. We know a lot from the Chinese communities. Some cultures do not have the word depression. So my question remains, and I think more research, whether there will be some disadvantage created for socially sensitive issues which come up as a side conversation during in-person visits.
Right, that they aren't able to bring up during the online,
Yes.
right? Yeah, and I can see both sides of the issue. On one hand, it is potentially a silver lining that we never had this before, the online visits, but you've raised so many potential concerns, and it's great that I know that you'll be monitoring this. So this is so important. We have another question. And I'm not sure to whom this is posed, so anyone can jump in. The question is, the issue of sustainable and increased funding seems to be a common problem throughout the session we've had this morning. Why do you think our government does not value our health system? Pat has jumped back on.
Actually, I went off because my husband was walking behind me. Can I jump in here?
Please.
I think there are a number of reasons. We've been cutting back actually on healthcare relative to the population for a long time, and we've been privatizing it. And I think one of the reasons for cutting back has been to create space for the private sector to come in and make a profit. And I think that's a real problem, because I don't think healthcare is a business like the rest. I think it's quite different. So I think there are multiple reasons. Our big austerity plans, our whole notion that we had to cut back on the public sector and expand the private sector because it's more efficient, more effective. I could go on at length, but let me say quickly in terms of why I think that it doesn't apply to long-term care, those notions that you get competition. We have no competition for nursing home beds in long-term care. We have a huge waiting list. They're guaranteed a full house, whatever kind of care they provide. So there's not quality determined by competition. And it's not about price, because all of the homes across Canada that are contracted to provide publicly funded care get the same amount of money. So we're not making any financial gains by doing this. What we are doing is having some of the money for care go to profit. So it seems to me we've made some really bad decisions in healthcare. And in some provinces, in Ontario, we have the lowest number of hospital beds in the country. We closed a whole lot of hospitals, and closing hospitals has been really, really important, because hospitals are where the Canada Health Act applies. And as soon as you go out that hospital door, or as soon as you move into an area of the hospital that is defined as an alternative level of care because you can't be fixed anymore, according to that definition, we can charge fees. And that also reduces. So I think that aren't very good reasons for failing to increase the funding to respond to the needs. And the final thing I'll say, because I could go on with this for 50 hours or more, is that we neglect to say how much care contributes to the economy. And we really need to think about that if that's our primary concern. So I'll shut up.
Thank you. And Farah and Sky, do you have comments on that?
Yeah, I would add, to me, at the larger policy making level, it is the short-term perspective versus long-term perspective. So, we are becoming very focused on, fixing the budgets, what do we need now, instead of what we need in few years. So that is a challenge, because these, in addition to what Pat has been saying, that, this perspective needs some shift. these things will have a rippling effect, a cumulative effect. If we don't address, for example, mental health now, what will happen? Those people will lose their jobs. Although maybe we brought immigrant to contribute in economy, now if they are depressed, they have PTSD or something, they might not be able to be contributing in the economy. So how are we thinking about mental health? Then the burden on the family, the rippling effect. So this is, I think, more comprehensive lens with a longer term vision, with the rippling effects, is something we need at the policy making. And I suggest, coalition, the groups where we have community representatives, scholars from diverse disciplines, having these table conversations with the policymakers is something to shift the current culture, which I'm seeing for policymaking. It's not easy to shift the cultures, but our role is to continue our work.
I think my panelists have said, I think like Pat, I'm like, oh my gosh, like how long do we have? I think you could talk, but I think my panelists have said it very well. And I would only add that, whenever we have, my first thought was whenever we have a government that sees its role as saving money in the short term at the expense of people's lives and wellness, as opposed to, building a happy, healthy, thriving society, which is not just an economic question, we get these results. But then I even thought, but the truth is, this is not even economically good politics, because not taking care of mental health care is much more expensive for the government. Like we know this, like in disability, lost work days, hospitalization visits, death, like there are so many ways in which this is actually financially terrible, as Farah said, and it doesn't build a thriving society. So really, for me, it's about misinformation. Like I just think that this government and these politics have really confused a lot of people about what cuts to these things actually do for them and do for us as a society. I could say so much more, but I'll stop there.
Not to mention the costs in prisons and the judicial system.
Yeah. Sure.
Perhaps related question then, and I'll pose this to Skye, but afterwards I'd like, if you would like to comment, all the panelists. Question was asked from the audience: what part do employers play in supporting our frontline workers and their health, not only physical but mental health?
Yeah, thank you for that question. I think a very significant a part. I think I could answer that on two levels. So regarding the question we just answered, when a government fails to provide for people, then that labor gets kind of shifted down to the next group of people, and that often does land on employers. So is this ultimately an employer issue? Yes and no. It is a policy, governmental, public health issue. But in lieu of that, yes, the employers also have a role, and in lieu of employers being kind of supported in supporting their employees, I do think that can fall onto employers. And there's a number of things that we know are really strongly associated with mental health, like, as Pat has been highlighting, like adequate working conditions, paid leave, paid sick leave, like reasonable hours, adequate pay, like socioeconomic status is one of the biggest predictors of mental health, of post-traumatic stress. So I think what happens a lot when employers are either trying to maximize their profits or they're squeezed because of the lack of support they're getting from like at the government level, they try and come up with quick fixes to these problems. Like, here's a mental health webinar, which is great, but it's actually not functionally addressing some of these problems, which really require, really at multiple levels, like interrogating greed, because I think they have these downstream effects. But I'm curious what my panelists think about that.
Yeah, go ahead, Pat.
Well, one of the things that we haven't talked about yet is the increase in unpaid work, which is primarily done by women. And that we're just finishing up a book on this, actually, talking about I talked a bit about the unpaid work by families in long-term care. The unpaid work done by the people otherwise paid for the job has also increased enormously. They work through lunch, they stay late, they come in early, they do things for residents who have no family, like, buy them shampoo and things when they're on their own time. And they go home so exhausted. Our surveys 10 years ago were showing that they stayed awake at night, worried about the work they didn't get done for the residents, which I think is important. But the other thing that we forget about is when we don't provide the care and we expect it to be handled in the family, by which we mainly mean women, that those women are themselves getting ill. They're getting ill from having to provide that kind of care. And they're trying to provide the care without the time, because they're also trying to be employed in order to put food on the table. But they're also doing it without the skills required to do the job. And so feeling inadequate when they're doing it. And the kind of stress on the household by not providing for that kind of care and public services. And therefore it spills over into the economy because they're not doing a good job at work. You can't be. I'll stop.
Yeah, exactly. And I was going to add, the one response from the system level, when there's not enough, funding coming from the policy level, is precarious employment, people who work without benefits, hourly wages, So then, this idea that employer covers some of it, that is not holding true. Over years, precarious employment has increased, hourly type of payment compensation approaches increased. So how are we then covering all these, healthcare aspects if they are not funded by the government, by the social insurance system? It's coming to their own pockets, and it's not affordable for many people.
Okay, we now have a question for Dr. Fitzpatrick. Might PTSD lead to changes in personalities for those affected between how they interact on Zoom versus in person? And if yes, how does one try to bridge the gap?
Really interesting question. It's hard. The reason I'm pausing, the reason I had a sharp inhale is I think any of my students, who are not here, but if they were, would probably laugh at me because they know that what I'm thinking is like, well, what is personality? Like, what does that really mean? And so I think that there's kind of two different ways of thinking about that. Most people are referring to like your enduring character or your sense of self. The concept itself is kind of a little slippery. So it's a little hard to answer in that way. Certainly, PTSD can impact the way one experiences themselves. The way one presents to the world, what they share, who they feel comfortable talking to, how they act, how they feel, how they have an identity, how they think about themselves. Absolutely. Would that change over Zoom versus in person? That's an interesting question, and it's probably very specific to the individual. So maybe, depending on the way somebody's thinking or acting, what makes them uncomfortable. I mean, PTSD is quite idiosyncratic. So I could imagine somebody who feels very unsafe in crowds or around people in real life who can feel much more comfortable and be much more animated on Zoom than they might be in person. I can also imagine somebody who feels much less comfortable on Zoom because there's less they can see, for example, of what people are doing. And 3,000 other variants, that would explain different things. So I would say it really depends.
Okay, and Farah, you may comment on this as well, since you're the e-health expert.
Yeah, so we are also doing a scoping review for virtual mental health care, among refugees and immigrants across the world. So some of that is coming up. If someone, for example, is experiencing, their asylum seekers, they have been living in tight spaces, detention centers, virtual mental health care delivery doesn't work for them. They feel very tight in that environment and uncomfortable. It is like a trigger for them to have flashbacks. So it really depends what their past experiences are. And I think, more, so there is some research, I recall this one is probably from Sweden, so there is some research on that that's showing that, there could be differences, but whether, it applies to all situations, I think more research we would need to do, and what type of those specific situations. The comfort of taking a client-centered perspective, I think the best will, in my view, is to have the first session in person, and so that you can understand someone's comfort, and then ask them if a virtual delivery is suitable for them, So a hybrid would go a long way where we can accommodate people's specific needs.
Excellent points. I have another question that I will pose to you, but first I'd like to remind our audience, you can type those questions into the Q&A at the bottom of Zoom. And so feel free to ask your questions. And I know that I too have so many questions. These discussions are really so close to home for all of us. So please go ahead, and now is your time to engage with our three panelists. We have a question from Paul, who asks, how do we reconcile that our Canadian healthcare system is ranked low on outcomes relative to other OECD countries and Commonwealth funded countries? We spend more, however, we have poorer outcomes relative to those countries. I see you nodding, Farah, and Pat as well. So who would like to go first? Pat?
We don't spend more than the United States, and we don't spend more in terms of public money per capita. We get the overall spending, and a lot of that spending is private, just as a starting point. And it depends on which outcomes you measure, secondly, and how you measure them. We measure, for instance, wait times. Well, wait times, they don't even measure them in the United States, just by the way. So we can't compare. But the methods of comparisons are often quite questionable, because when it comes, we often do it in terms of elective surgeries, in terms of how fast you get access to elective surgeries. Well, often it's because people wait in Canada because they want a particular surgeon who can only do a certain number of surgeries at a time, or because they want to wait till after their vacation, or when they come back from Florida, or whatever. I mean, it's a complicated method of comparison. And so I think we have to question the data to start from, and what it is we're measuring and how we're measuring them in terms of outcomes. But go back to per capita investment in public health, we're not at anything like the top.
Farah?
Yes, I was gonna add to that, the measurement is one issue, that what is counted as spending. Is it the public spending, or is it the combination of private and public, out of pocket and public? The other part is the bottleneck that we are now experiencing about health staff in the healthcare system. So, we are experiencing, shortage of staff. We are hearing news about ER departments shutting down for hours or days. So, and probably there is an effect of COVID-19 and people shifting their profession, or retiring. So that is I think it was there for a few years, probably. And now with the COVID-19, the situation is exaggerated. It has come up to the surface, and there has been a rippling effect. If people are waiting, for some longer time, because the surgeons cannot schedule them, the health starts to go down. So I think the balance is needed, that so that the people's health doesn't get worse because there are some bottleneck in the system. So we need to recognize and address the bottlenecks.
Yes, and I think we've heard that in the news recently as well. Feel free to pose questions in the chat. I've got another question from the audience. Mentioned in all of your lectures to all of the panelists, the relationship with either your frontline workers, family members, and healthcare workers are vital to how we care for patients' health. What is this kind of care? Why is this kind of care so important, but not often recognized?
Well, I can speak to why it's important, and then maybe the folks who are a little more systemic in how they think, or systematic, systems level, can maybe talk about why it's ignored. Okay, well, I mean, I'd say at our core, like, we're relational beings. Like, we, at least from a trauma perspective, what PTSD really wants people to do is avoid, right? Is to shut down, to not talk about what they've experienced, to not feel their feelings. And PTSD thrives in that kind of darkness because often what's keeping PTSD going is the way we're making sense of it. Like, we might be making sense of our trauma in ways that are unhelpful, where we might be really afraid of experiencing reminders of the trauma, even though it's not going on anymore. And the more we avoid it, don't talk about it, shut down, the more those kinds of thoughts are allowed to kind of run rampant in our minds. When we share about what we're experiencing and we have somebody with us who does not reject us, does not confirm whatever unhelpful beliefs that we have, kind of keeps a safe space for us, that's how we start to learn that what we're thinking might not be so helpful or accurate. And we start to kind of update how we understand what we're going through. It's often like a really interpersonal experience, and that can come from healthcare providers, but it can also come from our loved ones. We know that having people who, for example, give us space to feel our feelings in the wake of trauma and not kind of like invalidate us or shut us down are really, really important in helping us recover psychologically. So all of those things are really, really, really relational and interpersonal and a huge part of how we experience mental health. They're not always taught to healthcare providers, probably because they're focused on other things, in their systems, and maybe not as appreciated as they should be. But I defer to my colleagues on what they think is going on there.
Yes, do either of you have a comment? I mean, I think that, we have learned so much through the pandemic about the importance of our frontline and our healthcare workers. And as this audience member asked the question, really, it perhaps wasn't recognized before, and we're slow to recognize it now.
Yes, and I would like to add that, definitely because of COVID-19, the significance of social aspects and relationships have come forward, because the absence of that social support has triggered, the mental stress and burden on our mental health. Definitely. But, even outside the pandemic environment, overall in our society over the decades, what's happening is that, we are becoming more engaged in our workplaces, and we are spending a lot of time in work, or there is a more expectation from work. There's more use of, digital technologies. So even our private spaces sometimes are not our private spaces. So, with this industrialization of the society, there are some unintended consequences which have emerged. So the family time, the time with friends is shrinking. So unless we are very critically aware of it, we may lose the big picture. We may, young professionals, youth, may not pay attention to that. Oh, and then suddenly realize that I have lost my friends over 4 or 5 years of my studies, or, my 5 years in the first job. So I think I did some focus group with students, during the pandemic about their views, and they after first wave of the pandemic, when they were so attached to the digital social media, they realized that, oh, it is having a negative impact on their mental health. They are listening to deaths and cases all the time. And then already they were missing in-person contact with their peers. The university campuses were down, no library spaces for them to see what people are around them. So they became very aware, and they started to reduce the time, some of them on the social media on purpose. So I think there is a more need of critical awareness in the larger population, that because we have become very industrialized societies and digital, how can we continue our relationships?
These are great points, Farah. Pat?
So many things to say. The congregate care subgroup of the science table that I was on looked at people who went into long-term care without indicating they had any friends or relatives. People went in with fewer complex care needs, in part because they had nobody outside to help look after them. And even though they were theoretically, at least, in better health, they were more likely to die during COVID and from COVID, which is just to affirm Farah's point about, basically loneliness can kill you. And when we ask people in long-term care if there's anything better about long-term care than living in your private home, and one of the things they say, amongst other things, is, I've got company. There are people there, and I'd be all alone at home. That's one thing I was going to say. The second thing I was going to say is the loneliness of the care provider, of the, not just the unpaid one that I was talking about earlier, the family, but also of the doctor or the nurse that is trying to do that work alone in terms of primary care. When long ago, when Quebec was setting up their commission on healthcare in response to the government's initiative on the federal government's initiative, they set up CLSCs that were to be basically community care clinics that would know the residents, but also, the residents, the patients in the area, but also that they would know each other, and that you would have people to talk to and consult. You would have social workers, you had pharmacists, you would have physicians with different kinds of specialties that could consult and talk to each other, not based on the notion that you should know everything to start with, and that, or that you knew the single best right way, so that you would know the population. And that's what CLSCs were initially supposed to be about. They frittered away without enough support in many cases. But I think that in doing this, we have to think about care is a relationship, to go back to what I think we have all said, but it's a relationship that calls for time, and that the relationship that we have to think about the families, the staff, and the residents in terms of long-term care together, and in general in terms of the healthcare system.
Thank you, Pat. And we will have just one final question, a quick question for Dr. Fitzpatrick. And the question is, how would you pitch Couples Hope to healthcare providers who don't think that they need help?
Interesting. Okay. Interesting challenge. I think I could think about it a couple different ways. I mean, one is that the benefit of Couple Hopes is that it doesn't just target your individual well-being, it also targets your partner's well-being and your relationship functioning. And I think we all could benefit from, I mean, you know, relationship strengthening, enhancement, even if you already have a great relationship, it's like, you know, always good. So if somebody was very reluctant, I think I might pivot to those other targets and outcomes. Ultimately, if somebody really doesn't think that they need help, helping them is going to be tough, right? Like it's actually not going to be a very easy thing. So the psychologist in me would say, I actually wouldn't go to pitching that first. I would go, if I were working with this person as a client, I would go to understanding why they don't think that and trying to figure out why I feel differently. But otherwise, you know, for me, when it comes down to pitching the kind of PTSD targeting aspect of it, it's really this idea that a lot of folks who have lived with PTSD for so long, they start to think things are normal and have to be there that don't. So it's really about like, you don't actually have to feel scared all the time. You don't have to feel disconnected. That's not you, that's PTSD talking. And you may have gotten used to that, but that doesn't mean that that has to be a way that you have to live your life forever. Like you can actually imagine a world in which you're free of those things. So that might be the other angle I would think about.
Thank you, Skye. This has been such an interesting session. And I know that there's so much more that we could go on and talk about, and it's been really difficult for our panelists to, you know, have brief answers. It really is so much more to discuss. And I would like to thank our audience, thank everyone who has asked such interesting, engaging questions to our speakers. And thank you to our speakers for your thoughtful answers. Really, I'd like to thank you for being here to lead us through this important discussion that is so important that we learn more and more about in society. And on my part, it really has been an honor for me to host everyone this morning. And I would now like to turn it back to Julie LaFord for a few final housekeeping items before we say goodbye. So Julie, thank you to you and to the alumni engagement team. There's quite a team behind this event. So thank you for helping to bring this year's York Circle series to life.
Thank you, Jennifer, and thank you to our panelists as well. Feel free to turn your cameras off if you haven't already. This was a really wonderful session, as always, of York Circle, and a great discussion we've had this morning. And audience, as usual, it will be available on YouTube soon for you to share with family and friends. I just want to take a moment to remind everyone that this is just the first of our 4-part series this academic year, and we'll be back on January 29th. More details about that session will be sent to you in the coming weeks. Information about York Circle and all our events is available on our website, alumniandfriends.yorku.ca, which you'll see in the chat now. And don't forget to follow us on social media. You can find us on LinkedIn, Facebook, Instagram, and Twitter. Thank you again for joining us today, and enjoy the rest of the weekend in the really, truly beautiful weather. Until next time.